Thank you, Jean-Louis Capel. Good morning, everyone, again. There are seats in the front, so just coming. So my disclosure, I've done research and collaborated with a series of hemodynamic monitoring companies, but today we'll talk mainly about vasopressors, so it's probably less relevant for this talk. Why is talking about vasopressors important? Well, because hypotension is, of course, very important. And when we looked at data, even for patients that come to the emergency department, for instance, and they have one episode of hypotension that gets better with some fluids, and then these patients are sent to the wards, to the normal wards. Well, just having had an episode of hypotension in the emergency department is actually associated with worse outcomes. And as you see, the lowest is your value of systolic blood pressure that is being recorded, the higher is your mortality. So despite patients getting better and leaving the emergency department, these patients are at higher risk of having problems later on. Now, there is often a lot of debate about what is more important. Is it more important the blood pressure or the perfusion in terms of lactate and etc.? I think it's a synergy. They are both equally important. The way the human body has evolved is being made in a way to protect blood pressure at all costs. So usually a de novo hypotension is a medical emergency. So when we see a patient in the emergency department with hypotension, I think it is a medical emergency. It's telling us that the autoregulatory mechanisms of that patient are actually gone for the moment, and we do need to act very quickly. We can talk about it later in the disease of this patient, day 2, day 3 in intensive care, and we can think about maybe some more permissive targets, but at the beginning, a de novo hypotension is a problem. And when we put this data together with markers of hypoperfusion, for instance, like lactate, then I think it's very clear that we see a synergy between perfusion pressure and hypoperfusion in terms of lactatemia. So for instance, I could have the good patient that have a good blood pressure and a low lactate. We know that those are easy patients that they will do very well, but the ones that we're really focusing on, they come to our intensive care unit, they're a bit sicker. And as you see, I can either move in terms of increased lactate level for a good blood pressure, and the patient with a high lactate level and maybe still a good systolic blood pressure, still we have a pretty high mortality. We're talking about the range of 20%. Now, on the other hand, the patient with a low lactate level but significant hypotension and vasoplegia still will be associated with worse outcome. And if we put the two things together, really the synergy is really obvious. These are those patients with refractory septic shock. They will require significant vasopressors. They have very high lactate, and those are those patients with very high mortality. So in terms of hypotension, I think it's important to realize the majority of shocks probably will present with some certain degree of hypotension. However, as you've seen from the previous slide, it is possible that some patient may not have an overt hypotension. Maybe they run with arterial hypertension at home, and it's very difficult to spot them in the emergency department to understand that actually that's a much lower blood pressure than normal. So it is possible that we see patients with what we consider a normal blood pressure that actually, due to the fact that they're already having hypoperfusion, are still in shock. So indeed, in the consensus statement that we put in 2014, we said that while arterial hypotension is commonly present, it should not be required to define shock. It means that we should not rule out shock just based on a good blood pressure value. If we have evidence of clinical hypoperfusion and a lactate is elevated, that patient is still considered to be in shock, and as I said before, is still a patient with a high mortality that requires some prompt interventions. In terms of what to do with blood pressure targets, there is not a lot out there. There are more studies coming out. Probably the most important study is the study by the group of Asfar and Jean-Louis Teboul, one of our co-chairs, was one of the co-authors on this paper, going for a slightly lower target, slightly higher target of arterial blood pressure. They didn't find any difference in outcome in these patients, apart from a secondary analysis in which they looked at acute kidney injury, and in a secondary outcome in which they found that acute kidney injury was less prevalent in patients with a history of hypertension if they were treated with a higher blood pressure. But if you look also at the side effects were also higher in the higher blood pressure target. So it's not that we have to recommend the higher blood pressure in everyone with a history of hypertension, but what we thought is an understanding probably of the autoregulation and how this works on the organs of our patient. Autoregulation is something that happens in every organ. It's something that has been very well studied, for instance, in the brain a lot, but it happens everywhere. So probably what happens with the kidneys is that in normal circumstances, in normotensive patients, a mean arterial pressure of 65, which is lower than the average mean arterial pressure in the healthy population, is probably okay to maintain autoregulation. But in patients with a history of hypertension, probably 65 falls a bit short of the threshold value to maintain a good perfusion in the kidneys, and therefore in those patients we should aim for something a bit higher to keep the perfusion going. So in our consensus we say that basically we need to individualize the targets of blood pressure, because it does not depend just on being above or below 65 millimeters of mercury. It will depend on the disease and what was the pre-existing condition of this patient. We also say that we suggest a 65 as the initial target. It's a sort of a safety measure. So we are receiving a patient that is very sick. Let's go on safety first, and then we can start to think about individualizing. Our consensus was in general in shock, not just on septic shock, so we made some recommendation around trauma. But if you look at the septic shock patients, we also said we suggest, which is not a recommendation, is a suggestion, to consider a higher mean arterial pressure in septic patient with a history of hypertension if by doing this their kidney function improve, a sort of a noradrenaline challenge to see if this patient can actually get better with this. Now, I remember when I started medical school that I was taught about vasoactive drugs in terms of almost a clear separation between alpha and beta, and actually between vasoconstrictors and inotropes. And I was actually told that a vasoconstrictor increases the blood pressure, but usually the cardiac output decreases because there is a significant increase in afterload. However, I would argue that this paradigm has been considerably shifted in the last decades by a series of papers, and also by probably a better understanding of the physiology of the cardiovascular system, especially in states of shock. Why is that? Well, if we have a situation of sepsis, vasodilation is the predominant mechanism there, for which at the beginning cardiac output will drop. It's not that we are losing volume, and probably the capillary leak at the very beginning is not the prevalent mechanism. So what's happening is that we're vasodilating the system, so I have the same amount of volume but in a larger capacitance, and that means that my stress volume is less efficient to maintain a mean systemic filling pressure to drive my venous return. Now, what we do with those famous 30 milliliters per kilogram is probably trying to restore the mean systemic filling pressure by giving a significant amount of fluids, considering that the capacitance has increased. However, we can think that we may be able to achieve a similar effect in the increase in the mean systemic filling pressure, not by acting on the volume that we put in the increased capacitance, but by trying to restore a decreased capacitance in the system. How does it work? Well, if when we give fluids, we try to climb the Frank-Starling curve of our patient, hopefully thinking that we are on the ascending part of the Frank-Starling curve, when we give fluids, we move from one mean systemic filling pressure to the next mean systemic filling pressure. And we do hope that by giving fluids, really, if we are working on this, the venous return curve and the cardiac function curve will intersect in this point, so that giving fluid would increase the cardiac output. Now, if the effect of a vasopressor was purely an increase in mean systemic filling pressure, and therefore moving to a higher mean systemic filling pressure, what I would see would be this similar effect in terms of increases in cardiac output when I give a vasopressor in this condition. The truth is the vasopressor, they don't act just on the capacitance, they also work and interfere with the microcirculation, with the resistance of the system. So what happens is that, yes, we are increasing the mean systemic filling pressure, but also we are changing the resistance to the venous return. And for simplicity, what happens when the resistance to the venous return increases, it's a bit like shifting the curve a little bit bottom down. And that means that the overall effect of an increase in cardiac output for patients that respond to an increase in cardiac output to vasopressors is actually overall a bit less than what would have been just with fluids. But still, the majority of septic patients, when they're giving a vasopressors, especially at the very beginning when they're hypotensive, we are recruiting stress volume, so it is not true that the cardiac output will fall. In the majority of those patients, the cardiac output will increase as a response to the increase in vasoconstrictors. And that gives us the ability to actually to gain some time and potentially to then catch up with the fluid loading and optimize the patients. Now, some patients may decrease cardiac output, and if we measure cardiac output, we will be able to see this effect. So how could it be that the same drug may have different effects on the circulation? Well, let's imagine we start in a similar setting. Now, again, if the effect was just the effect on the capacitance of the system, I would still see an increase in cardiac output by climbing the Frank-Starling curve. However, we said that we are detecting a change in cardiac output which is going down. So there are two things that are happening. Either the resistance effect is much more predominant here. It means that we're really squeezing the microcirculation. We are really increasing the resistance of the system, and therefore the cardiac output decreases. However, physiologically, this would not make complete sense if it was not shifting the cardiac function curve, because we know that when we increase the vasoconstriction in our system, we also see the CVP usually increasing just by the fact that we are increasing the vasoconstriction, and therefore the capacitance is reduced. So what happens is a combination of effects. We are increasing the resistance, and at the same time, we are shifting the cardiac function curve, an effect probably related to potentially an increase in afterload in these patients. So it is only when we see a predominant effect on afterload and the resistance effect is so marked that it is possible to see a decrease in cardiac output. Now, if we were giving a talk around cardiogenic shock, probably this could have been a more prevalent mechanism there. For the majority of patients in septic shock, actually what happens is that an early use of a vasopressor normally would increase cardiac output. And that's why we do advocate actually not losing too much time, especially in patients that are very hypotensive, if we have to give a vasoconstrictor. So that's the physiology on how vasoconstrictors may rise the blood pressure and change cardiac output. In terms of which drug to use at the bed space, a few papers that have come out recently, probably this physiological effect of the fact that the noradrenaline per se can increase cardiac output explain also why the studies that have compared vasoconstrictors against pure inodilators, actually they didn't show significant changes. And for instance, this is a paper by the group of Gilali and Nang in which they couldn't find any difference between dobutamine versus dobutamine norepinephrine versus epinephrine in this group of patients. And the group of Mayburg again looked at epinephrine against norepinephrine. They couldn't find significant differences there in terms of hemodynamics. The interesting bit, though, is that the epinephrine was increasing the lactate production. This is a normal mechanism for this type of vasoactive drugs, and that doesn't not mean that the outcome of those patients will be bad because of the increased lactate. There is an increased production of lactate, which probably is used as energy. However, I would argue for a drug that does not bring clinical advantages compared to noradrenaline, it makes our interpretation of lactate levels more complicated because it becomes a bit more difficult to see what is the kinetic of lactate in this group of patients. The group of Daniel De Backer did one of the most important studies in the field. This was published in the New England Journal of Medicine in 2010. At the time, there was still a big debate between which would have been the first vasopressor of choice between dopamine and noradrenaline. They found that while the outcomes overall were similar for the two groups, the side effects for the dopamine were much bigger, and that led pretty much universally to abandon the dopamine as a vasopressor of choice. There are still some units that use it. Personally, I don't. I think with the data on safety that we have now, norepinephrine should be our first vasoconstrictor. In recent years, some emphasis has come towards vasopressing, the rationale being that there have been observational studies that show that patients that are in septic shock and they had worse outcome at lower levels of vasopressin, which is a hormone that is normally secreted in our body, and therefore it makes physiological sense to probably try to replace this hormone in states of shock. The group of James Russell did this on the first study, which was the VAST trial. They found a trend, but it was not really significant, so it didn't really prove the vasopressin was better than noradrenaline at this stage. However, on a secondary analysis, there were some suggestion and some signal that potentially on the less severe septic shock patients, and the interpretation of the authors was that maybe on the early phases of shock, vasopressin could bring a survival benefit, and potentially in a secondary analysis, in a secondary paper that was done again by the group of Russell and Tony Gordon in London, they found that there was a potentially beneficial effect in terms of acute kidney injury in the early phases of septic shock for vasopressin compared to noradrenaline. This led us to the Vanish trial, which was a trial that we did perform in the UK, led by Tony Gordon, and in which exactly we compared vasopressins versus noradrenaline in the early phases of septic shock. So all of these patients were randomized well before being for less than 6 hours on any vasopressors. The research question was around acute kidney injury 3 days. What we found actually there was not really any difference in the acute kidney injury, and in this group of patients. We have a secondary analysis going on at the moment looking at the potential use of renal replacement therapy. However, based on the current evidence, I don't think we can recommend vasopressin as a first-line agent in septic shock, and I do think that noradrenaline still maintains the lead in terms of being the vasopressor of choice in this group of patients. I'm just going to conclude showing you some physiological research that we've been doing over the last few years. We've developed a lot of tools in the last 20 years, and the group of Jean-Louis Teboul has been seminal in this, in trying to understand how to give fluids, how to predict which patient will respond to fluids. Somehow we don't have the same physiological variable for understanding when to start, when to stop vasopressors, and which patient will benefit more in terms of this. One of the things that we started to explore was the arterioventricular coupling that occurs normally in everyone, in healthy individual, but is more interesting, of course, in a group of septic patients. And the way to look at arterioventricular coupling was proposed by Michael Pinsky by looking at pulse pressure variation over stroke volume variation as a ratio between the two. The rationale being that this ratio could actually give us an idea of what is the dynamic arterial elastance of the patient, which again reflects the arterial load somehow and the arterioventricular coupling of this patient. We did a series of studies, and the first one was done by the group of Ignacio Monge in Cadiz, in which they were able to show that the dynamic arterial elastance was able to predict which patient would have increased not only cardiac output but also blood pressure in fluid-responsive patients. And then we started to validate this methodic, and we were able to show that even in spontaneously breathing patients, where the single variable of pulse pressure variation and stroke volume variation, they're not really valid, actually the ratio between the two still holds. And we're able to show that, again, the ratio was able to predict which patient would have increased blood pressure as well as cardiac output. So why that could be important? And again, this is more research at the moment. There are a few devices that are coming out there that are trying to use these physiological principles, but we don't really have a way at the moment to apply properly at the bedside, even if there are studies coming out. Well, I think it's very important to realize that any drug that we give can have some side effects. If when we are giving a vasoconstrictors, we want to increase blood pressure, potentially cardiac output, it's equally important when we have stabilized the situation and when the drug is not needed anymore, I think, to wean off that drug and that support as fast as possible. And we do have observational data that show that actually failure to do so probably brings this patient to a significant exposure to vasoconstrictors, which is associated with worse outcomes. So in this sense, it is interesting that there are some groups like this French group of Guinaud and Lorne, in which they started to look at whether potentially they could use this principle of the dynamic arterial elastance actually to wean off vasopressors, so to understand which patient could safely be stopped in terms of noradrenaline and wean off the noradrenaline a bit early. So it's early stages, but watch this space. So in summary, the vasopressor effect, remember, is not only on blood pressure and will depend on the filling, on the circulation, on the cardiac function curve, on the microcirculatory resistance. I think we do know what not to use at the moment. I would argue that it's good not to use dopamine, and I would advocate that it should not be your first choice vasoconstrictor. However, I don't think we have a lot of evidence of what is the best vasopressors at the moment. Personally, I think until I don't get more, I still go with noradrenaline first. I would say based on all the physiological rationales and some of the data that we have, it's also important to treat hypotension early. And as we keep saying in these days, I think in sick patients, let's not monitor just blood pressure, but also cardiac output and cardiac function, and maybe CVP.